Hey all, Eric Christensen from the Real Life Pharmacology podcast. I am a big podcast listener. I like learning different things and just stumbled across a podcast that fits right in my wheelhouse, and I'm guessing it'll fit in yours as well. You got to check out the Mechanism of Action podcast. It reviews a lot of history about where medications came from and were derived. It's really going to help your understanding of medications and also be a little bit entertaining as well. So go check that out. Highly recommend it. Mechanism of Action podcast. All right, on the podcast today, we're going to cover H2 blockers. H stands for histamine, and 2 is obviously a receptor subtype. So just a little differentiation here. H2 blockers, so that's histamine 2 receptors. Those are in relation to the stomach and gastric secretion. H1 blockers, or histamine 1 blockers, are your traditional antihistamines that help with runny nose and those type of things. Your loratadines, your Zyrtecs, your Benadryls, those are more H1 blocking agents. And the H2 blocking agents include antacid GI medications like famotidine, cimetidine, nizatidine, and ranitidine. Now, ranitidine is off the market, but now it's back on the market. There was a kind of unique metabolite that showed up when it sat too long on the shelf. And so it's now been reformulated just recently within the last year or so here. It has been released again. I can tell you from my perspective, I have not seen it prescribed yet, and I really doubt, I'm probably going to see it much. So the most common H2 blocker you're going to see is famotidine, brand name Pepcid. Next one, cimetidine, maybe. I do see a little bit of Tagamet occasionally. I'll kind of tell you why that isn't used terribly often coming up here as we talk about these drugs. Nizatidine, I don't see too much of that, but brand name there is Axid, but I do see it occasionally. And in general, when comparing H2 blockers to proton pump inhibitors, as their antacid capacity goes, they tend to produce less potent acid suppression. One upside potentially to the histamine 2 blockers, to the H2 blockers, they may work a little bit more quickly. And again, reminder, they do that. They reduce gastric acid secretion by competitively blocking histamine 2 receptors on gastric parietal cells. They tend to have a little bit shorter duration of action, so you might see them dosed twice daily, a little bit more often than the PPIs. Often in troublesome patients, I do see this dosed a little bit more at night. So if patients kind of have refractory GERD, very serious GERD, or other gastrointestinal issues, I often will see a PPI dosed in the morning and then see an H2 blocker dosed at night to kind of cover dual mechanisms, and then obviously kind of give it at different times there as well. So famotidine, again, that is the most, brand name Pepcid, that is the most commonly used agent I see utilized. Renal impairment, there are dose adjustments for all of these with renal impairment, so that's an important thing to pay attention to. So these do not irreversibly inhibit, proton pumps. So it's more of a competitive inhibition with H2 receptors, which, again, ultimately reduces acid secretion. Quick onset, I alluded to that, faster than the PPIs in general. Duration's a little bit less for most of the H2 blockers compared to PPIs. And so, like I said, it's probably a little bit more likely you see an H2 blocker dose twice daily there. All right, let's talk metabolism quickly here. I kind of alluded to renal dysfunction and that these should be dose adjusted based upon renal function. Famotidine really doesn't have a ton of hepatic or liver metabolism as far as its breakdown goes. However, cimetidine can have a bunch of interactions via CYP enzymes, and that is really one of the primary reasons why you don't see cimetidine used terribly often. All right, so let's dig into that a little bit further before we kind of get to adverse effects. So cimetidine, or brand name Tagamet, is rarely selected because, again, it inhibits numerous CYP enzymes. So CYP1A2, CYP2C9, so that can be a big interactor with warfarin. CYP2D6, we have lots of psych drugs that are broken down by CYP2D6, and CYP3A4. So numerous medications are broken down by CYP3A4. So very, very important to remember that cimetidine has a bunch of drug interactions. Absolutely need to educate your patients about this. There's, warfarin I alluded to, phenytoin, some of the benzodiazepines occasionally. Again, tons of drug interactions here. If you've got somebody on cimetidine, needs cimetidine, I would probably prefer to see famotidine utilized to avoid and minimize the risk for drug interactions. If that's not possible and we have to be on cimetidine for a specific reason, definitely make sure that you're looking up drug interactions with this medication. Adverse effect profile, usually the H2 blockers are pretty well tolerated in general. Couple things to note. If you're stopping these medications abruptly, we could get that rebound hyperacid secretion. Rarely, particularly maybe more so with cimetidine, we can have some reduced libido, erectile dysfunction type adverse effects. Rarely, gynecomastia has been reported as well. Again, typically not with the others, but I have seen that with cimetidine on a rare occasion. Possibly increase in galactorrhea, and this potentially being done by increasing prolactin effects. So again, not crazy common, and again, these aren't typically common with famotidine. More so with cimetidine, and again, kind of another one of the reasons, along with the drug interactions piece of it, why famotidine is preferred over cimetidine. Other generalized adverse effects from the H2 blockers, headache, dizziness, those can definitely happen, but are pretty rare. Kind of those generalized adverse effects. Occasionally, you may see some CNS changes, maybe some confusion and delirium type symptoms. Again, extremely, extremely rare. More common in elderly patients and those with poor renal function, okay? Which I think makes sense, right? We need to dose adjust based upon renal impairment there. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, geriatrics, NAPLEX, or many others, go check out meded101.com/store. We've got a growing list of resources there. We've helped thousands of pharmacists prepare for and pass their exam, and we can absolutely help you too. So all those links, meded101.com/store. If you're a pharmacy technician, nurse, med student, we've got books, we've got educational materials, we've got review courses, we've got fun activities like crossword puzzle books. Go check out all those links, all those resources at meded101.com/store. Help support this podcast and support the sponsor. All right, so I kind of covered cimetidine drug interactions a little bit. I did want to also mention that the drug class H2 blockers as a whole can cause some potential adverse effects and drug interactions. So acid suppression, similar to PPIs, can impair the absorption of some oral medications. So azole antifungals are kind of a classic example here. The other thing I wanted to mention was B12. So these medications have been associated with B12 deficiency. I would say historically, I don't think of them as strong of an impact on B12 deficiency as PPIs. However, it has been reported in the literature that it can potentially reduce B12 levels. So when I think about drug interactions, I think about metformin having that additive effect on lowering B12 levels. And then, of course, if you have a patient on a PPI and an H2 blocker combo, that definitely is something to think about and may exacerbate B12 deficiency a little bit more than you might expect with individual agents on their own. So just summing up a few of these points, some of the most important things to recognize and remember, famotidine is the most commonly used or the preferred H2 blocker in most patients and by most clinicians. Definitely the one I see most commonly used in practice. These H2 blockers do need to be dose adjusted by renal function. So as patients age, as renal function declines, definitely pay attention to that. Again, we can have some rare CNS type effects if these medications accumulate a little bit. Cimetidine, numerous drug interactions, inhibits numerous CYP enzymes. Also uniquely can cause some gynecomastia and potentially impact prolactin levels and cause sexual dysfunction as well. H2 blockers, comparing them to PPIs, they may work a little bit more quickly, but don't generally provide as strong or as potent acid suppression as the PPIs do. And then ranitidine, it has been removed from the market. But with the recent reports in the last year or so, it has been reformulated and now potentially is available. Again, I haven't seen it yet out in practice, so maybe that will make a comeback. Maybe that won't. There are some restrictions on needing it to keep it in the same bottle and some of that stuff. So I would guess with some of those nuisance patient education points, famotidine is definitely still going to remain the top dog and the most commonly used H2 blocker that you're going to see there. All right, well, that's going to wrap up the podcast for today. Be sure to go check out my podcast on PPIs if you're looking for more info there. I've also covered a lot of these drugs individually in the past. So if you want a little deeper dive specifically on an agent, go check out reallifepharmacology.com, hit the podcast tab button, and search for the medication that you're looking to learn a little bit more about. With that said, if you got any comments, questions, feel free to reach out to me, mededucation101@gmail.com. If you enjoyed this episode, do me a huge favor, leave a rating, review on iTunes or wherever you're listening. And of course, support the sponsor, meded101.com/store. All your purchases there go directly to help fund this podcast, and I'm greatly appreciative of that. With that, I'm going to sign off for today. Thanks so much for listening. Take care and have a great rest of your day.